Shannon, it's 7:30. Go ahead and get started.
Yes, let's go ahead.
Yes, please.
It's good. Good morning, everyone, and thank you for attending our Grand Rounds lecture as part of the Natalie and Jack Congdon Visiting Scholar in Cardiology Lectureship. I am pleased to introduce to you our speaker today, Dr. Prabhu. Dr. Prabhu is a Tobias and Hortense Lewin Distinguished Professor of Cardiovascular Diseases and the Chief of the Division of Cardiology at the Washington University School of Medicine in St. Louis. Dr. Prabhu is a heart failure cardiologist, a physician scientist, and mentor. His extensive research has focused on the role of inflammation and the immune system in heart failure, from a novel identification of the importance of the cardiosplenic axis in ischemic heart failure to his current work in cell autonomous mechanisms of inflammation in heart failure related to macrophage circadian clock dysfunction and the role of alternatively activated macrophages in cardiac remodeling. Dr. Prabhu has won several awards, including Established Investigator of the American Heart Association, the Robert Byrne Lecturer of the American Physiological Society, the George E. Brown Lecturer for the American Heart Association, and membership in American Society for Clinical Investigation and the Association of American Physicians. We are very grateful for Dr. Prabhu's expertise on this topic and look forward to learning from him. At the end of the lecture, we will leave time for questions. Please submit questions via the chat function on Zoom as they arise during the talk. We are pleased to offer both CME and MOC credit for our Grand Rounds conference series. To claim credit for today's session, text the code shown at the beginning and end of this presentation to 804-625-4041. For questions or to log into your Cloud CME account, visit vcu.cloud-cme.com or contact Shannon Winston. I will now turn it over to Dr. Prabhu.
Well, thank you so much. Thank you for the invitation. Thank you for the honor of being the Congdon visiting scholar, and thanks to the Congdon family for supporting this lecture. I hope in the next 50 minutes or so that I can look at heart failure with you through the lens of the immune system and try to understand how inflammation plays a role in progression and whether or not we can manipulate this therapeutically. These are my disclosures. But my research focuses on this field of cardioimmunology, which has been burgeoning of late, as we realize there are very, very strong and intimate links between the immune system and cardiac remodeling and heart failure. And we've known for many years that heart failure is a state of chronic inflammation. But what I'd like to emphasize is that underneath this inflammatory milieu, there are pathological alterations of immune cell networks that contribute to remodeling, and that we might consider heart failure as an autoinflammatory or even an autoimmune disease in the right condition. So, these are two MRIs. One is a normal heart, and obviously one is a heart with ischemic cardiomyopathy and bad left ventricular systolic dysfunction. And as heart failure cardiologists, we have foundational therapies as well as additional therapies for this disease. And I've kind of just summarized them here from a review article in JAMA Cardiology. We're all familiar with this. They're the pillars of renin-angiotensin inhibition, neprilysin inhibition, adrenergic inhibition, aldosterone, and SGLT2 inhibition. And we also have a 10% of the population with advanced heart failure that can be treated with left ventricular assist devices and heart transplants. Well, all of these therapies are really geared towards an understanding of pathophysiology that's based on either the hemodynamic model or the neurohormonal model, if you think about it. But there's a whole other aspect of heart failure that we are not manipulating for therapeutic benefit. And this is related to inflammation and the inflammatory model. Years ago, and even currently, there was the cytokine hypothesis of heart failure. And in recent years, we've understood that the cytokine hypothesis really is just a manifestation of immune cell activation. So in ischemic cardiomyopathy specifically, and in dilated cardiomyopathy, we have progressive augmentation of inflammatory mediators, progressive inflammatory activation. This is an example showing a foundation inflammatory cytokine tumor necrosis factor, TNF, which increases in the serum with increases in functional class or decline in functional class. And this occurs both in the serum and in the heart tissue itself, both with dilated cardiomyopathy as well as ischemic cardiomyopathy. And these are of prognostic import. So if we look at inflammatory mediators, such as TNF or interleukin-6, for example, or receptors for TNF, we see that the higher the levels, the worse the cumulative survival. And there were multiple animal studies that suggested that if we could intervene in this process, we might improve outcomes. So how can we target inflammation in chronic heart failure? Well, these are potential approaches. We could have targeted anti-cytokine therapy. We could have anti-inflammatory therapies. We could have true immunomodulation, or we could target autoimmunity. So what really are the results of the phase 3 clinical trial? So there have been many small studies that have hinted at benefit, but really for us to move into a therapeutic venue with this, we need to understand what the phase 3 clinical trials are. So here is a list of phase 3 clinical trials, and from a review article we did a couple of years back, showing the large trials with targeted anti-cytokine approaches, anti-inflammatory therapies, and immunomodulation. And if you look, really, the results were quite disappointing for most of these trials. In fact, highlighted here that in some trials, for example, the anti-TNF trials, there was a signal of no benefit and potential harm. So this was very disappointing to the field until 2019, when the CANTOS study came out. And here we did see in a sub-analysis, that there was a signal of benefit for heart failure hospitalizations with CANTOS, with canakinumab rather. So let's look at this trial in a little bit of detail. So CANTOS was a trial. It wasn't really a heart failure trial. It was a trial of stable atherosclerosis. So these patients had a history of prior MI and high CRP, and were randomized to 3 doses of anti-interleukin-1 beta, canakinumab, every 3 months. And the primary outcome you could see there was a 15% reduction in MACE and 31% reduction in all-cause and CV mortality if there was a reduction in CRP to below the median. And you could see the curves here showing that there was a significant reduction in the primary endpoint with canakinumab, for example, at 300 milligrams, or 150 milligrams, the middle and highest doses, as well as key secondary endpoints with canakinumab. Well, so this was not a heart failure trial per se, but a subsequent study looked at patients in CANTOS that had chronic heart failure baseline. Unfortunately, LVEF was not measured at the time of randomization, but there was a history of chronic heart failure or prevalent heart failure at the time of entry. And what was seen in this analysis is that treatment with canakinumab resulted in a dose-dependent reduction in hospitalization for heart failure, and the composite for heart failure hospitalizations or heart failure-related mortality shown here. So this was the first kind of large-scale clinical trial that suggested that if we could intervene or target an inflammatory process here with interleukin-1 beta, and we might impact the outcomes that we see in patients. Well, we also have data from smaller trials for meta-analyses. This was a meta-analysis of 19 randomized controlled trials of both anti-cytokine and broad immunomodulation. While there was no change in all-cause mortality, there are signals that immunomodulation will improve parameters of remodeling with a reduction in LV size and an improvement in LV ejection fraction, suggesting, again, of the hint of benefit if we block the inflammatory or immune response. We also have data suggesting the opposite, that we can look at immune markers as a predictor of recovery. in addition to predictors of progression of disease. So this is a study, the IMAC-2 study, which is the intervention in myocarditis and acute cardiomyopathy. So this was recent onset heart failure, recent onset cardiomyopathy. And what these investigators, Dennis McNamara and his group, Wilson Tang, showed that if we had a particular type of antibody against the beta-1 adrenergic receptors, IgG3, that this was predictive of improvements in left ventricular ejection fraction in 6 months. So we have signals that suggest that the status of the immune system can be linked to both progression and regression of disease. And so what is going on here, and how could we understand this better? So what I'd like to emphasize is that the trials that have focused on protein mediators and cytokines and so forth are really the tip of the iceberg. And the cells that are generating or producing these cytokines really are primarily immune cells. And I've just kind of laid it out here that they're innate immune cells and adaptive immune cells, including macrophages and monocytes, neutrophils for innate immunity, and T and B cells for adaptive immunity. And they're linked together by antigen presentation. So we wanted to ask the question, what role do immune cells play in cardiac remodeling? And how does the hematopoietic system, the immune system, link with the failing heart? So I'm going to show some studies that raise several points. Some are in the mouse model and some are in humans. But I'll hope to integrate all of this in the end. So the first point I'd like to make is that there's robust innate and adaptive immune cell expansion in the failing heart. And actually, this occurs both locally and systemically. So here, this is a mouse model of ischemic cardiomyopathy, where we produce coronary ligation. And in 4 to 8 weeks, we have pretty reliable ischemic cardiomyopathy. You could see it on echo. We see alterations in filling. We see cardiac enlargement. On the histological levels, we see myocyte hypertrophy and interstitial fibrosis. So this is a reproducible model of ischemic cardiomyopathy. So if we look at that tissue and stain for immune cells, here we used a macrophage marker, MAC1. What you can see is that there's an increase in the number of macrophages within the failing heart, actually about a 2 to 3-fold increase. And we can also see this with other innate immune cells, such as dendritic cells, here close to a 5-fold increase with staining. And we see this with a variety of T cell populations as well in the failing heart. And you can see we've outlined here CD4 T cells, CD8 T cells, and regulatory T cells marked by this marker FOXP3. So in the failing heart, there's expansion of both innate and adaptive immune cells. So the question is, does this happen in humans, and what are they doing there? So in humans, we have the availability of failing heart tissue from patients undergoing left ventricular assist devices or cardiac transplantation. We also have control specimens here. This was when I was in Alabama, so we got this from the Alabama Organ Center, from hearts that were not technically usable for transplant. But what you can see here is that if we stain for macrophages, again, using CD68, a pan marker, you'll see that there are macrophages in control or non-failing hearts. But this is really augmented in failing hearts. So this is the apical core of a failing heart that has undergone left ventricular assist device placement. 2 patients showing an expansion of these CD68 macrophages. And these are the same patients at the time of transplant. What you see here is if you mechanically support the heart, we see a marked reduction in the inflammatory cell levels, the innate immune levels in the failing heart. And this is quantitated here, substantial increase in the number of total macrophages in the human failing heart with a reduction at the time of implantation. So we can look at this with a little more specificity and resolution using flow cytometry, where we can take human failing hearts, digest the tissue, isolate mononuclear cells or the immune cells, stain with antibodies, and get an idea of what is the milieu of both innate and adaptive immune cells in heart failure. And so this is an example. I'm not going to go through all of this, but suffice it to say that we've isolated leukocytes from human failing hearts. identified both CD3 positive, CD4 positive rather, FOXP3 positive T cells. So these are CD4 positive helper T cells and regulatory T cells. What you see is much like in the mouse ischemic cardiomyopathy model. In humans, we see a marked expansion of total T cells, helper T cells, and regulatory T cells. And so this and many other studies led to a working hypothesis that we published now 3 years ago, that in heart failure, we have not only a expansion of the non-cellular effectors of inflammation, such as protein mediators or cytokines, but we also have an expansion of the cellular effectors of the immune system. So both innate immune cells and adaptive immune cells are expanded in the failing heart. And these cells are, based on multiple studies, are inducing tissue damage that over the long run leads to a phenotype that we commonly associate with pathological cardiac remodeling. So in essence, this suggests a response to injury hypothesis, so that we have an acute injury, for example, myocardial infarction, that leads to a very high level of inflammation. But if the infarction is big enough, for example, or if the mechanical load is sufficiently high, we have reflex systems that are activated, which leads to lower levels, but persistent stress on the cardiomyocyte that leads to a state that we call para-inflammation, or low levels of chronic inflammatory response. And this over time leads to a situation where initially inflammation is a reparative process, but over time with chronic inflammation, this leads to progressive tissue destruction, overall harm, and progression of left ventricular remodeling. So the second point I'd like to make is that while we're looking at the local effects in those prior studies in the failing heart itself, the inflammatory response is really systemic in heart failure. And here I'd like to show you just a few studies from the same mouse model, showing that the heart and the spleen actually talk to each other in heart failure, in ischemic cardiomyopathy. So we term this a cardiosplenic axis in heart failure. So this is a slide of just at baseline. There are many immune cells that are in the tissue milieu in the heart. There's resident macrophages, there are dendritic cells, T cells, and so forth. And every organ, including the heart, has resident macrophages that are tissue reparative, and stimulate angiogenesis and really minimally inflammatory. But once there's injury, this resident homeostatic macrophage population is replaced by macrophages that are derived from circulating monocytes that express this receptor, CCR2. And this is CC chemokine receptor 2. And I bring this up because this might be a potential therapeutic target for modulating inflammation. But these macrophages are much more inflammatory. They impede repair, and they produce tissue damage. In the mouse, they are derived from these Ly6C high monocytes. So if we look then at flow cytometry again, this is again from the mouse model, from a sham operated heart or a failing heart. And here we're looking at this marker, CCR2, in macrophages marked by these MERTK and MHC2. What we see is in failing hearts, we see a marked increase in the CCR2 positive population. And this is quantified here, so that in heart failure, we see a shift in the proportion of macrophages such that we have more of these pro-inflammatory CCR2 positive macrophages. And these are generally derived from the bone marrow and the spleen. So when we started these studies, we did note that the spleen is reproducibly and reliably enlarged in ischemic cardiomyopathy. And this is an example. As cardiologists, obviously, and myself included, we don't really think about the spleen, but this is something that was staring us in the face. And if we decided to look at the spleen, and what we see is that from this is a sham operated mouse, and this is a failing heart failure mouse, there's marked remodeling of the splenic architecture, and there's expansion of these, the white pulp, the expansion of these so-called marginal zones, rather the and there's an expansion, thickening of the marginal zone of the white pulp. And the terminal centers are increased, and this is a response that one might see with a autoimmune response, such as in lupus, and we were seeing this in ischemic cardiomyopathy. And if we looked at the tissue level in the spleen, what we saw is that there were dendritic cells. These are professional antigen presenting cells that spatially reorganized. These are these red cells going from the red pulp into the white pulp into the periarterial lymphatic sheath. So these cells were then in close proximity to T cells, suggesting that there was antigen presentation and activation of adaptive immunity. So what does this all mean? So what we did to find this out is we took splenocytes from mice that had heart failure. These are isotype mismatch, so we could track these cells. And we injected them into normal mice, and we waited 8 weeks. And what I'd like to show you here are 2 echocardiograms in mice. One is with 8 weeks after splenocyte transfer from a normal sham-operated mouse, and one is after a heart failure splenocyte transfer. Now, what I hope you could see is that there's actually systolic dysfunction in the heart failure splenocyte adoptively transferred mouse. So we can quantitate that here over time. We see an increase in end-diastolic volume with a transfer of splenocytes from heart failure mice to normal mice, a reduction in the ejection fraction, not a huge amount, but significant nonetheless. We saw an increase in heart size with immune cell transfer. And if we looked at the tissue, we saw that these cells localized to the heart. They were marked by this isotype 45.2, and that they were in areas of pockets of fibrosis, suggesting that they had home to the heart and were inducing tissue injury and were primed to induce cardiac damage. And more than that, we also saw the reproduction of systemic inflammation if we had transferred the splenocytes from heart failure mice to normal mice, with an increase in spleen weight and a change in remodeling of the spleen reminiscent of heart failure. So essentially what we've done is we've transferred the remodeling phenotype with adoptive transfer of immune cells, which to us was a revelatory finding, and suggested that immune activation is really a key driver for cardiac remodeling. So this led to a hypothesis that we had of a cardiosplenic axis in ischemic heart failure, suggesting that as the heart remodels from a normal size heart to a dilated dysfunctional heart, much as we saw in cardiac imaging, for example, that there's also a parallel remodeling of the spleen with splenic enlargement, augmentation and changes in splenic architecture suggestive of an autoimmune or autoinflammatory response, and actual trafficking of splenocytes to the heart, where they localize in the failing myocardium and result in the phenotype of cardiac remodeling. So, and indeed, if we looked in the spleen, we have an entire series of studies showing that there's increase in memory T cells, antigen experienced T cells, and that some of this can be reproduced with T cell transfer from heart failure into normal mice. So the first part then is that conclusions from the first part is that there's innate and adaptive immune cell expansion in the heart and lymphoid organs in chronic ischemic heart failure, that activated immune cells, including these CD4 T cells that I didn't show you, they're polyclonally activated, contribute to cardiac remodeling, and that splenic immune cells home to the heart to induce immune cell-mediated injury, and this is retained, this memory, immune memory, is retained on adoptive transfer. So we might think of ischemic cardiomyopathy as being in part an autoimmune cardiomyopathy. So we really should think about what are the specific immune cell populations we might target, or the specific antigens responsible for the activation of these immune cells. And this may be a better approach to therapeutic immunomodulation as opposed to just cytokine targeting. Okay, so that was in mice. What about humans? So is there immune cell activation in human heart failure? So at the same time that we were doing some of these studies, there was a study that came out from the Brigham Group that looked at patients with acute coronary syndrome. And this is not heart failure, but acute coronary syndrome. And these patients underwent PET scan, FDG PET. And what was observed is that when a patient comes in with acute coronary syndrome or plaque rupture, there was systemic activation, metabolic activation of the hematopoietic system in the bone marrow, the secondary lymphoid organs in the spleen, and even remote plaque in the aorta. So there was systemic immune activation in patients with acute coronary syndrome. These are control images for comparison. And more than that, the degree of hematopoietic or splenic FDG uptake or metabolic activity correlated with arterial activity and was linked to outcomes. So this was a proportion of patients free of cardiovascular disease, splitting up into less than median or greater than median bone marrow FDG uptake and splenic FDG uptake. And you can see that the curves really diverge markedly when you have high metabolic activity in the bone marrow or the spleen. And these authors didn't see this with metabolic activity in subcutaneous adipose tissue, for example, as shown here. So does this happen then in acute heart failure? So these are some studies that are ongoing where we started this in Birmingham, we're now continuing it in WashU, that we're looking at patients with new onset acute decompensated heart failure. So these are primarily patients with first-time presentations. And in these studies, these were HFrEF with LVEF of 28% on average and a significant LV dilatation. So this is a FDG PET of one patient with acute heart failure. And what you see is that there is, much like the study, from that I showed you earlier, there is an increase in the standardized uptake values for PET uptake in the bone marrow. And you can see the values here, they're quite high. In this patient, there was also a mild degree of leukocytosis and a very significant decrease in ejection fraction. And we also see uptake in the spleen. And here the SUV values are actually significantly higher. And we see this, we saw this in several patients, and this is ongoing now, but this suggests that much like what we see in the mouse, that in patients with acute decompensated heart failure, this is a highly inflamed process with metabolic activity in both the hematopoietic and the lymphoid systems. And if we do flow cytometry on blood that we've collected from these patients, and this is just showing a gating strategy to identify monocytes. In humans, we use different markers, but there's three groups of monocytes: non-classical, intermediate, and classical monocytes. What we see here is that there's an expansion of all the monocyte populations in the humans with acute decompensated heart failure. And this extends to T cells as well. So the same things that we're seeing in the mouse model with ischemic cardiomyopathy, we're also seeing in humans with acute decompensated heart failure, with an increase in CD4 helper cells, CD8 cytotoxic T cells, which persists in patients that we had repeat measurements even after their acute decompensated event has resolved. So again, suggesting persistent and ongoing inflammatory activation. And we saw this also with regulatory T cells as well. All right, so we see then that there's expansion of innate immunity and adaptive immunity. We also see that in patients with acute decompensated heart failure, there's an increased stimulus for immune cell trafficking. And what we have here, this is neutrophils that have been isolated from normal humans. They've been loaded with a dye, a green dye, and we've taken plasma from patients with either normal patients or patients with acute decompensated heart failure, and we've put them at one end of a well to assess motion of these neutrophils towards the heart failure plasma. And what you see here is that there's random motion without plasma. There's some motion towards plasma in from naive patients, but there's a much greater motion of neutrophils towards heart failure plasma, and this is quantified by this vector analysis. And we can see that there's significant stimulus for immune cell trafficking in acute decompensated heart failure. So this suggests that we can look at acute decompensated heart failure, again, these are first-time presentations, as a series of immunoinflammatory endotypes, that we can define this through a combinatorial approach using cardiac imaging, such as PET MRI, using blood flow cytometry, other biomarkers and clinical characteristics. And perhaps we can then define a endotype-specific therapeutic immunomodulatory strategies. That would be the goal. We're still a long way away from that, but the hope is that we can, if we pursue this approach, that we can go backwards along this progression so that we can go from what was thought to be irreversible to a reversible phenotype in terms of remodeling. In other words, go backwards along this spectrum of progression of chronic inflammation. So is there evidence is there evidence that suggests that we can do this? Certainly in mice, we can target specific immune cells. I haven't shown you all the data here, but not just our studies, but many other groups, that if we target, for example, monocytes, macrophages, regulatory T cells, other T cells, that we can reverse cardiac remodeling. Again, the potential approaches that we can use include monoclonal antibodies targeting these specific cells. We've shown you data from the canakinumab study. We can use specific anti-cytokine approaches. We can do broad immunomodulation, or we could target autoimmunity. However, getting there from a mouse model to a human obviously is a long road. We have to identify targets and biomarkers, validate them, have imaging biomarkers and therapeutic development, and we need to have large animal testing. So what is the current state in terms of potential immunomodulatory targets? So these are randomized clinical trials of anti-inflammatory drugs and biologics that have been repurposed for heart failure. And you can see that these are relatively small studies, at the most 260 patients or so. But many drugs have been tried: prednisone, pentoxifil, IVIG, and so forth. And there are ongoing studies, if you look at clinicaltrials.gov, exploring targeting this CCR2, which I mentioned earlier, which seems to mark a potentially a very pro-inflammatory subgroup of monocytes and macrophages that could potentially be repurposed, or rather not repurposed, but used in heart failure. Right now, the only CCR2 targeted approach is an atherosclerotic cardiovascular disease risk, but we believe that this could be extended to heart failure. All right. So the fourth point is that we need to understand biomarkers. And I'd like to point out that immune cells generally have a short lifespan. So the number of immune cells that are circulating are a result of bone marrow production, and that myeloid activation is actually a marker of cardiovascular and heart failure risk in humans. So we can switch gears to heart failure preserved ejection fraction for a minute. There was a recent paper looking at a post hoc latent class analysis subgrouping of the TOPCAT study, which was a trial of spironolactone in HFpEF. And these investigators noted that the three phenotypes, you could see them here: P1 with normal LV geometry, P2 with concentric remodeling, more in older women, and P3 with concentric hypertrophy, the so-called cardiometabolic heart failure phenotype, which was more predominant in men. And in both P2 and P3, there was inflammatory activation with biomarkers of innate immunity and or inflammation. And in fact, these phenogroups really had the worst prognosis in terms of the primary endpoint in TOPCAT, or death or heart failure hospitalizations. So if we looked, we did an analysis of TOPCAT Americas, simply looking at a simple biomarker, the white count, thinking that that would be a reflection of myeloid activity or leukocyte production from the bone marrow. And what we saw is that if the median white count in TOPCAT was 7,100, and this stratified patients into a better or worse outcome. So if patients, all comers here now in TOPCAT Americas with a high leukocyte count over 7,100, had a greater cumulative proportion of the primary outcome. either using a Cox proportional model or a competing risk reduction model. And if we did these incident rate analyses, what we see is that there was a continuous relationship between white count and the primary outcome in TopCat, CV, heart failure hospitalization, as well as all-cause mortality. This was a look at the we adjusted for 20 variables, and myocardial infarction. So that the status of the hematopoietic system, here just reflected by the white count itself, seemed to mark patients with a worse prognosis for cardiovascular outcomes in HFpEF. And more than that, it is a marker of cardiovascular mortality in patients without heart failure. So this is an analysis that we did of the NHANES cohort. And NHANES was a patient group that had no prevalent cardiovascular disease at entry. So these are people without any heart disease. And if we looked at several immune markers in those patients, what we see here is that multiple parameters were linked to cardiovascular mortality using a variety of statistical models, 4 statistical models. We saw very high, strong relationships between monocyte lymphocyte ratio, here in green, as well as neutrophil lymphocyte ratio as a predictor of cardiovascular mortality in this cohort. And you can see here the curves using both Cox proportional model or competing risk reduction. And apologize for that. What you see is a monocyte lymphocyte ratio. Here, the median was 0.3. If you had a higher ratio than 0.3, you had a significantly worse outcome with a adjusted hazard of 36% increase in the cumulative hazard. So the white count, the monocyte lymphocyte ratio, neutrophil lymphocyte ratio, they're all important biomarkers of cardiovascular risk that reflect immune or hematopoietic activation. So this brings me to the last point, and that is that there's recent data expanding on that concept of myeloid activation of something that is called clonal hematopoiesis of indeterminate potential, or CHIP. Many of you may be familiar with this, but what this is a presence of an expanded hematopoietic stem cell clone, somatic clone, which has mutations in leukemia driver genes. So this was originally looked at as leukemia markers, whether a somatic mutation in hematopoietic stem cells would augment malignant transformation. So what it turns out is that when you have these somatic mutations, some of these clones may have a survival advantage, and you can develop what's called a myeloid bias and more pro-inflammatory myeloid cells. And this will increase the inflammatory milieu, the propensity to inflammatory activation. And as we have seen, this will increase cardiovascular risk in multiple disease types, including heart failure, but also atherosclerosis. It's been shown in aortic stenosis, as well as thrombogenesis. So if you compare CHIP, the presence of CHIP driver gene mutations, especially in DNA repair enzymes such as TET2 or methylation enzymes, DNMT3A, what you see here is that the presence of these mutations in these CHIP driver genes are as strong or sometimes stronger predictors of cardiovascular outcomes than traditional cardiac risk factors, including things like hypertension, obesity, and so forth. So this is a very powerful risk factor. The presence of CHIP mutations increases with age, and we all know that age is a significant cardiovascular risk factor. So this associates CHIP, the presence of mutations, associates with heart failure. And this has been shown for both HFrEF, here showing that the presence of DNMT3A or TET2, these methylation or DNA repair enzymes, will result in clonal expansion and will reduce survival free of heart failure, death, or hospitalization if you have these CHIP driver genes. And recently, Ken Walsh's group showed that this also associates with outcomes in HFpEF. So this is a HFpEF model. Again, looking at these DNMT3A or TET2 mutations, there's an increase with clonal hematopoiesis CHIP driver genes positivity for heart failure-related hospitalizations in HFpEF with the presence of these mutations, as well as a worsening of clinical phenotype in these patients. So let's go back then to the CANTOS trial. So we're looking for biomarkers that can predict risk, specifically in this, for the sake of this talk, the risks of heart failure. So this is the prevalence of patients with CHIP mutations with age in CANTOS. You can see that it increases significantly as patients get older. In comparison to several other trials, they're in line with this increase with age. And again, these two, TET2 and DNMT3A, are the most prevalent CHIP variant genes, but there are many others. And there was an exploratory analysis of the CANTOS trial done last year, looking to see if CHIP, the presence of CHIP, could be a biomarker for response to anti-inflammatory therapy. And here, this is patients without CHIP. This is patients with CHIP. And this is patients with a specific CHIP driver gene mutation in TET2. And then this is non-TET2. So what you see here is that the TET2 mutation marked the patients that would respond to canakinumab in terms of reduction of MACE. And so this is an exploratory analysis. It was a subgroup, but I think that this suggests that we should look at novel biomarkers that reflect the inflammatory status in the myeloid system, and that we might be able to segregate people into more pro-inflammatory versus less inflammatory phenotypes of heart failure, for example. So the implications then is that for these studies is that humans with new onset acute decompensated heart failure have innate and adaptive immune cell expansion with hematopoietic and splenic metabolic activation. There are also increased plasma chemotactic signals for innate immune cells in humans with new onset heart failure. And that we might be able to define immunoinflammatory disease endotype to help direct therapeutics. And this would require novel markers of myeloid bias, perhaps such as CHIP, perhaps other markers of myeloid activity in order to take this further. And so I hope, I think I'm on time here, that immune cell activation is an essential mediator of disease progression in heart failure. I hope I've convinced you of that. And that we do need further study as to the antigens responsible for adaptive immune activation, as well as potential cell autonomous mechanisms that stimulate innate and adaptive immunity. And that so targeted immunotherapy may potentially be explored as part of the treatment toolkit for heart failure. And here, I would think that we might be entering the biologic age where, much as in oncology, where the biologic and antibody treatments have exploded based on an understanding of underlying mechanisms related to the immune system, might we be entering that age in heart failure as we understand more of the immune cell biology in this disease? So with that, I'd like to stop. Thank all of the folks in the lab through the years and my various collaborators on all of these studies. And thank you again very much for the invitation.
Thank you very much, Dr. Prabhu. That was an excellent talk. If you have any questions for all of our audience, please put them in the chat. In the meantime, I have a few questions that came up for myself during that chat.
Sure.
The first one, if it's okay. So regarding the white cell count, we frequently see heterogeneity in white cell count in acute MI patients. Some patients come in with a big STEMI, but they have a pretty low white count. Some are in the 50 to 20 range. We wonder, is there something else going on additionally? Would it be reasonable to have a higher concern for that patient population, that the higher the white cell count, the worse they might do, even with a good vascularization?
Yeah, I think that's an important observation. I do believe that augmented white cell count suggests a more robust inflammatory response. And I think that we should be a bit more concerned about that kind of patient. Now, remember, these studies that I've showed you was really not in the acute MI setting. This was more, chronic heart failure. But I think that that's not, that's a rational approach. That's a rational way to think about it. Yeah.
That's good. We have a question and a comment from Dr. Huizar, one of our electrophysiologists. He says, great lecture. How can we explain the increased motion of monocytes based on the movie you presented in plasma? What makes them move? I noticed is that we're also in a less populated image. How would the number of cells or cell density would affect their motion?
Yeah, so the image, the video that I showed was actually neutrophils, and they were, we had put plasma as a stimulus for their chemotaxis. So what that showed is that in the plasma itself, there are multiple factors that attract immune cells. So immune cells need to traffic from the bone marrow, the spleen, and so forth. And so there has to be a stimulus to draw them out to the circulation so they can get into tissue and things like that. So what we're seeing in the acute decompensated state is just a very highly inflamed situation that are drawing leukocytes out into the blood, and we think inducing damage.
Makes sense. Question from Dr. Hundley. Says, thank you for the wonderful presentation. Are there data to suggest how exercise or increasing activity may modulate activation of the inflammatory cascades in patients with or at risk of developing heart failure?
Yeah, no, that's a really interesting point. As far as large scale data, I'm not sure, but certainly in humans, I mean, but certainly in multiple models, I think exercise might be a natural anti-inflammatory. And I think that it is very worthwhile to pursue whether exercise might be an immunomodulatory therapy. So I think I would expect that regular exercise would suppress detrimental inflammatory cascades.
Makes sense. I have one more question while we see if anyone else has any other questions. So this one came up when I was thinking kind of in anticipation for your talk. So does immunological memory apply here to a lot of things that you've been discussing? For instance, does the inflammation that gets triggered by a second or a third MI trigger a more potent inflammatory cascade that would lead to a worse hit in systolic function? Or if somebody had like a bad myocarditis or a bad episode of COVID, are they more susceptible to developing a reduced EF from an MI than somebody that hasn't?
Yeah, no, so you bring up a really good point. So let's take the MI model, for example. So in an acute MI, the spleen actually, with the first MI, in mice at least, if you take the spleen out, you make the healing worse. In other words, with that first MI, you have to have an influx of immune cells from the spleen that then lead to wound healing and repair. So the spleen in that acute MI setting is a healing organ. However, the character of the spleen changes, I believe, in heart failure, such that it becomes much more pro-inflammatory. So this suggests that if you perhaps, what you can envision is if you have your second infarct, a more inflammatory spleen might not heal as well, the heart, when you have a second infarct. And would this then contribute to a progression of ischemic cardiomyopathy? So we've all seen patients that have perhaps smaller infarcts and yet can progress their disease. And I think there's a complex interplay between the fidelity of wound healing after infarction and the progression of remodeling. Now, having said that, there might also be a possibility that you can actually change the milieu of the immune cells in the myocardium after an infarct, such that they may be more resistant to subsequent injury. So it's not the spleen here, it's the local milieu in the heart itself. And we might think of that as almost a preconditioning type response, not the classical preconditioning, but for lack of a better term, the immune cell milieu is more resilient to a second infarct.
Makes sense. Got to wonder how much more susceptible the sickle cell patients with splenectomies are also. Dr. Abate says, great observation and great example of translational research. Could you comment on the role of IL-6? There are several phase 3 trials ongoing with IL-6 blockers, such as Zeus, Hermes, Artemis. What is your prediction?
Yeah, I'd probably ask you, Antonio. You're much more involved in the cytokine space with anakinra and other things, but it's interesting. There's a trial of IL-6 inhibition also in HFpEF that I was talking to one of our speakers that visited here. I don't know what the result will be. I would like to think that we will see a positive response with IL-6 based on the cascade that we have with CRP, et cetera, but obviously unclear. The TNF studies were pretty disappointing. The IL-1 studies, at least the IL-1 beta studies, still haven't been shown in a true heart failure population. Perhaps you could comment on some of your anakinra work. I think that's more perhaps a smaller scale in terms of a large trial. But yeah, we'll have to see. The proof will be in the pudding.
Yeah, maybe I can comment. I want to give the credit of a lot of faculty members at VCU who led the heart failure experiments with me when I was there. We're continuing now. It will be intriguing to see how the cytokines modulate the monocyte populations in these patients. And so I really enjoyed this lecture. I'm looking forward to these IL-6 large trials to see what they show. Our limited experience, small numbers, were encouraging. And actually, I saw Corey Tranquil is on the call. He's one of our junior faculty at VCU, and he led a sub-study of the CANTOS, where we took patients who had a heart failure at time of enrollment. And in that small group of patients, there was an improvement in peak VO2 and EF that was promising and encouraging. As you mentioned, the sub-study of heart failure didn't really look at the details in the larger group. So really exciting time to be in cardioimmunology.
Agreed.
That's good. Well, if there are no other questions, thank you very much again, Dr. Prabhu, for taking the time to speak with us. We've all definitely enjoyed learning from you. And then I believe Shannon had that code up, so everyone please text that to get your credit for the lecture.
Well, thank you very much for the invitation. I really enjoyed it. Thank you.